All right. Thank you for the kind introduction. And, the only bad part is after the very engaging discussion with Ariana and Joe, I've almost forgotten what I'm going to speak. So I'll just have to recollect. But, I'm here to really talk something that's pretty close to my heart. I think so also critical for the future of the healthcare system and give you a preview of what's the value proposition of building the foundational blocks of a learning health system that can support, I would say, a very preventive, proactive, personalized approach to manage chronic conditions, including cardiometabolic diseases, as well as to make it a reality. Now, almost 4.5 years back, when I was welcomed into Houston with big smiles, of course, tasked to create a contemporary preventive cardiology program around a robust clinical service line, let's train the future generation. But very specifically, that's relevant to the conversation here was, how can we think about putting in the infrastructure that we can generate new knowledge from our own community to understand their own specific needs rather than relying on national registries, which I think so are great for academic curiosity, but give us little insights what's actually happening in our backyard. And, of course, tasked with this immense challenge and to innovate and creating a foundation that can meet our aspiration, I can tell you was pretty daunting. But of course, I try to keep myself focused around 5+1 core principles. And really what they are and saying, look, let's focus on thinking about impact rather than trying to meet academic and social media matrices. Be dedicated to solve the biggest problems and do it incrementally and in an integrated fashion. And let's not think about short-term success and remain focused on longevity, long-term success, as well as the sustainability. But one of the key elements was, let's make sure that we focus where we think we can make an impact beyond the immense contribution that's happening all around us, be it Baylor, Texas Heart Institute, UT Southwestern, and beyond, many institutions, DCRI, Johns Hopkins, Brigham and Women. So as we were thinking about it and contemplated, where do we came to focus? And I think so the opportunities for us really narrowed down to this immense potential of health system data, yet pretty much untapped. And why were we excited about it? And then again, the reasons are clear. We are in the most transformative era, I would say, of data generation in healthcare, be it from our EMR images, point of care testing, sensors, a trend that shows no sign of slowing down. And now you couple that with the plummeting cost of omics and availability, you can create an infrastructure of rapid discovery within your own ecosystem. And not to forget the advancements in the geospatial domain that's happening, and Dr. Kindi spoke earlier about it, that's allowing us to think beyond the health systems, urban planning, population health, equity, disparities, and much more. But of course, I don't need a reminder here for most of us that, yeah, data is the new oil, and this is where the most application are. It's transforming anything and anything we do. For example, just this morning, having to look at the Google map, what time and how long would it take me to get here, due to the generosity of everyone on the road. And I'm asking, can we aspire a world where every patient in the health system is contributing the data so the next patient is better off than the prior one? The sad reality is that doesn't happen in our health systems. And of course, we can speak for almost an hour or more, but two main reasons is we all know that the healthcare system data is hoarded. In spite of living in a day of, I would say, data overload, I would say paradoxically, we are in an information drought. So the second other reason is that we haven't really found out the best way of utilizing and refining data. We're still doing it the old ways, in the very redundant ways of data mining and refinement. And if we aspire to do something like what Google is learning with every click or Tesla with every mile, or Amazon with every purchase, we have to have a shift in our mindset, almost a 180-degree shift where we are riding the digital health and automatized industrial processes of not only collecting, but making the best use of it. By the way, no such playbook exists. And now in this context, we had a very audacious plan for our startup strategy and say, let's create the capacity and the expertise where we can take all the Lego blocks of the healthcare system to create the most comprehensive platform, harmonizing the entire health system data for as many domains as possible, for as many people as possible, so that it can snowball down on the aspirations that at least we had for our cardiovascular community and beyond. And literally working for the last 3 years under the hood with no academic productivity to show, not even a tweet to show. Finally, at least we came up with where I think we're able to create a remarkable digital twin for our entire EMR, a huge data foundry that has harmonized almost 1.9 million individuals from an entire system, cross-sectionally, longitudinally, with validated outcomes, creating an automatic pipelines to pick and harmonize that truly allows us to quickly dive in to find answers from our own community. And look, I'll give you today a little bit of a bird's eye view on some of the opportunities. For example, just the local insight on the area we're talking about, for example, obesity. Just in our own health system, you can see almost about 1 in 3, 33% are overweight, with 38% obese, with several categories, with 1 in 14, 80,000 patients in our own system with a BMI of more than 40. Now, thinking about the future, if you look at the young age, 18 to 39, almost 1/3 to a quarter of those individuals are there. So if we're thinking about the future and trying to prevent the future complication, this is a space where we need to invest. Now, we also have to realize that in the higher obesity groups, we see a predominance on the non-minority white, and of course, the issue of addressing disparities. And this information is critical as we're thinking about population health effort. Now, among the group and many of us, we're thinking about cardiometabolic, just understanding the biology. There is a lot of, I would say, a valuable role of biomarkers. Imagine deep diving into this asset with a treasure trove of more than 750 million labs. You can deep dive into what you're looking for. For example, half of these individuals have lipidomics. You can look about 75% for their renal function. If you're looking for structural disease, BNP marker seen in 15%, inflammation in 10% of that. And of course, we spoke about fatty liver, and we can estimate like with the FIB-4 score and saying what could be the estimation. So we have tremendous information. Now, medications provide us a snapshot of our quality of care. Now, something that's very interesting for this conference, SGLT2 and the GLP-1s from the cardiometabolic, just getting an insight on the prescription patterns. And we were having a lot of conversation about who's the right candidate. What about access, cost, equity, and the impact? Clearly, this type of information is going to guide us. And then if you have an ability, really, to link all your outpatient, millions of outpatient with millions of ED and inpatient encounter, it gives you an oversight on the entire journey through different settings. So this is equipping us with information that can help us guide where are our best return of investment and where do we need to focus? How can we optimize the healthcare delivery for better outcomes? Now, of course, this is just the EMR. There are many other things that it's happening that we can plug in. For example, ongoing enrichments that happening beyond our health system, where we're trying to tap into a lot of other resources, be it Medicare, state, national, ACO, National Cancer Data Set, a lot of effort led by Dr. Sadir Ilkindi, looking beyond what we have information within our health system. This other ongoing enrichment, it's not only about structured data. We can take a lot of unstructured data on imaging, for example, with advanced methodologies. We've been able to convert the entire unstructured data for 200,000 echoes into R&D ready data happening with coronary CT angiogram for more than 20,000 individuals and many more. Parallelly, we have created the pipelines, again, effort led by Dr. Al-Kindi, where we're ingesting the imaging DICOM data to create specific radiomic pipelines for various clinical and R&D applications, and some of the ones highlighted here, giving us deep understanding about various adiposity measures. If you're thinking about biology, this is also helping us enriching the linkages of existing biobanks. Almost 350K individuals discarded blood that was collected during the COVID era. Next step, we are trying to collect almost more than 100K samples from individuals with diagnosis of cardiometabolic, and moving forward, collecting high fidelity samples from our own preventive cardiology clinics with 15,000 patients coming each year and 10,000 patients getting CT angiograms. I think this will guide us on the biology and the processes a lot more in the next 2 to 3 years. Of course, we spoke about social determinants and how your zip code information may be more valuable than your genetic code. And clearly, we have shown that various measures based on zip code on national data set is associated with not only the presence, burden, and poor outcomes in cardiometabolic disease. The question is, can we use that within our own EMR registry? Now, just having access to your address and zip, you can look at a wide range of markers of social vulnerability, area deprivation, environmental justice, walkability index, your nature score. And actually, we have shown that you can absolutely do that. And in essence, 20% or more of our population are within that most socially disadvantaged group. Now, of course, how is it helping us internally? It is, what are we learning is that just these information with social zip code based, we can truly identify the most at risk and socially disadvantaged population. Clearly, as you can see, that the more disadvantaged neighborhood have the highest prevalence of obesity, especially seen in non-white minorities, are double jeopardy. But yeah, at the same time, if we can go back and work with our policymakers and think about urban planning and make our neighborhoods more walkable, even if you account for social disadvantage, individuals residing in walkable neighborhood have a 21% lower risk of hypertension, 33% lower risk of diabetes, and 40% lower risk of obesity. This is the take-home message. I'm not showing you registry national data. This is from our own backyard. And not to forget the role of pollution, which is critically important. And I think so as policymakers and as Houstonians, we all need to come together, because clearly the disparities you're seeing at areas with heavy pollution, individuals residing on that with a much higher independent risk of having coronary heart disease, stroke, and now we're finding diabetes and CKD. And you can even go further, as Dr. Al-Kindi has shown. With this high intense, hand-picked exposomic data, you can actually refine it even further with satellite imaging and Google mapping to create an individual level exposome fingerprint, which, by the way, I'm not surprised, predicts your cardiovascular and cardiometabolic disease risk more than any other risk factor or biomarker. Clearly an opportunity for all of us here. So while this is great, one may argue, okay, what's the RO? And sorry, one more thing. And this is something very near and dear to me with continuous monitoring linkage. Now, the bio button, for example, and many others, where you can get more extensive vital sign measurements per day, 7,000 patients now expanding to 6 other systems and going into the outpatient, it's going to open a whole new door around the precision medicine and will give you information around gait, posture, steps, and many others. I think so this is where the future intersection of AI, big data, and healthcare lies. So, while all has been great, the question is what has been the impact? I think so the biggest impact for us was it led to a significant scholarship focused on and for our own communities. That was the key thing, engaging our own scholars, early career folks. And for me, the major personal interest is going deep into the cardiometabolic. Just to give you a few examples how data from our community and for our community is helping us. Just as we spoke this morning, we found out almost 3/4 of individuals who have atherosclerotic cardiovascular disease based on the recent clinical trials now meet in our own system criteria for semaglutide. Well, if you look at the reality, only 1 in 25 are on it. And so the question is, how do you scale it? How do you identify the appropriate patient? That has helped to build us a specific cardiometabolic obesity clinic, which is taking the lead here. Now, of course, there are so many of these individuals. Do we treat everyone? Are they the same? Actually, within our own health system, we're finding that's not true, and work led by Dr. Al-Kindi has shown in overall, you can classify them into 3 big groups. One, which is the most highest, with the highest BMIs, almost gender equally distributed, not many minorities. They don't have too much of social disorders, and actually are a pretty lower risk of cardiovascular disease. On the other hand, the second biggest group, more minorities, socially disadvantaged, much higher risk of heart failure, CKD, and CVD. Maybe that's the group we need to find. And the third group, elderly, mostly male, white, more risk for cancer. Do we really need to move with the semaglutide in that direction? So clearly guiding us the future where we need to be. And of course, weight loss is on everyone's mind. And as you can see, we clearly showed that in our own system, there is a huge divergence who loses weight. It all depends upon the dose and the actual BMI. So key insights in that. And then it's also helping us grow niche programs beyond cardiology now, cardio-onc metabolic, as well as cardio-room metabolic. Other things is it has allowed us to become a part of a large national consortium, the PCORE-Net, where we are contributing 2 million of our data to have access with 11 million individuals, where we can compare what's happening in Houston versus rest of the country. Other thing is we spoke about implementation. Now actually we're taking the care into our communities, addressing social determinant of health, and also looking at the value of remote blood pressure monitoring. So rather than the community coming to us, we are going back to the community. And a key area, which is really an area of interest, is we have now created this unparalleled capacity and infrastructure that we are thinking about building the next digital health institute, bringing under one roof high-tech computational engineers, clinicians, operational leaders, and commercial leaders to say, can Houston become the next digital hub of the country? And the plan out here is really to accelerate discovery, development, our local deployment, commercialization, and dissemination all across the nation and beyond the world in the AI space, as Rihanna spoke about. So, but another thing that is really near dear to me is that what we have built is allowing us to build the next infrastructure around precision medicine initiative, where more deeper phenotyping can help us unravel the mysteries in a system biology approach, actually trying to look at what's happening beyond the 4 walls in your daily life with variables, biobanking, exposome evaluation. And we're starting this with genetic dyslipidemia, hopefully moving to adiposity and inflammation next. So, micro steps. We took our micro steps almost 3 years back, and I think it has accumulated in creating an amazing, robust infrastructure that I think we can quickly move to take the data and learn from it with knowledge and wisdom. And I think it has given a significant ROI to us. In the short period of time, it has allowed us to create deeper expertise in various domains, a huge source for scholarship, career development, brought in tremendous amount of grants, but also supporting many clinical programs. But this is great, but I think this is just the start. And I realize that we cannot do it alone. And that's why I'm here, especially a message to my colleagues in Houston, and be it early career, established leaders, policymakers, industry partners, that we have a great opportunity building up that alliance to do things together and addressing the most important issues that are affecting our communities in our own backyard. And TMC has a great opportunity here. So, you know, I wouldn't be speaking here if it wasn't the connective tissue, all of these individuals who helped create this capacity where we can together look into the data, where we can harness its power to impact lives, alleviate suffering, promote prevention, population health, and enhance resource utilization. But the one thing that I think that unites all of us is in deep philosophy that every effort that we do and every byte of data and every algorithm is in the service of our stakeholders. And it should help improve health outcomes, promote health care, prevention, but more importantly, in doing so that we are helping our caregivers and receivers in this way. So Joe is not here, but kudos to him in putting this alliance together. And I hope that at Houston Methodist, we can in our way contribute in this journey. As I've always said, it's not about impact factor, it's all about the impact. So let's do it together. Thank you so much.